Hopkins and such. So that's the bias I bring to this discussion.
Thank you for that. I appreciate that. Why don't we start off, Fred, by just kind of talking a little bit about COVID-19 itself, infection and disease. Like, what do we know now? What's the current information about what's happening right now?
Sure. Well, we know a lot about the virus itself, its structure. We're learning a lot more about its function, and that's really how it causes disease. And for better or worse, the fact that we're into this now several months and have the experience from China and Italy in particular, we have a better understanding of the disease, which I don't think was very well understood initially. We know a lot more about it, how that virus, it's RNA virus, there are a lot of viruses. We've been through 2 of these pandemics before with this type of coronavirus, the SARS and MERS, as I think most people know. Clearly, the primary symptoms are pulmonary. And initially, this was thought to mimic a fairly common severe lung disease that has the acronym of ARDS, acute respiratory distress syndrome. So a lot of the early patients in China and Italy and the US were treated the way these patients are typically treated, with high pressure ventilation. Well, it became evident, I think some of the best studies out of Italy in particular, that this was probably exacerbating the disease in a lot of individuals. And part of that provides an understanding for the disease. Looks like the virus really interferes with the microvasculature of the lung and perhaps other organs as well, causes inflammation, and that really prevents the gas exchange you need to be able to respire properly. So high pressure forced oxygen can really damage the lungs in that kind of situation. And we're finding that other therapies such as just early nasal oxygen or CPAP or proning or variety, so interrupt me if I'm using too much jargon here, medical terminology, but we're finding better ways to treat this as far as the lung disease. What we also found out pretty early on was that this does provide some cardiac symptoms as well, probably primary cardiac disease. Other viruses certainly are well known to cause cardiomyopathies. This could be one of the long-term problems with this particular type of infection. There's clearly a coagulation problem, and that's probably the result of the way this virus interacts with the microvasculature. Some of the sequelae of that are strokes that we're seeing reports of an increased number of strokes in certain cohorts that normally don't suffer from a high incidence of strokes. And I don't want to get into the molecular aspects, but we have pretty good understanding of the molecular aspects of what this virus does in the lung and probably in other tissues as well. And at the effector end, a lot of inflammatory cells are stimulated. They release a lot of mediators that then cause damage. And normally what happens in an immune inflammatory response like that is you can dampen that response once you react to whatever the infectious agent is. And the problem for some individuals is that doesn't happen. And we talk about maybe therapeutic interventions. That's one of the ways perhaps to effectively treat people who have severe disease with this as well. It's interesting because the transmission of this is thought to primarily be through aerolized transmission, but there are data now showing that there's probably some high incidence of the virus in stool. And so potentially, don't have data yet, and again, with most of these things could be, but the risk of oral fecal transmission is there, since there seems to be late stage presence of virus in stool as well. You know, the pandemic is borne out, as with a lot of these viral pandemics. I can get into that later, but again, SARS, MERS, you know, you can go back to influenza. We have seasonal influenza, of course, in the US, and we know how devastating that is. And the real problem for the healthcare delivery system has been that this comes on top of seasonal flu, which is an enormous number of folks who are hospitalized and tens of thousands who die every year as well. This is on top of that, and really has made, in those areas, New York and Detroit in particular, having real problems being able to meet the demand that has been put on the emergency services and the intensive care units, critical care units to treat these patients. Oh, I can't hear you.
You had referenced SARS and a couple other.
Yeah.
Can you put this? A lot of stuff's in the media. It's so hard to kind of muddy through all what you see and what you read on social media. We were talking about this before we started, and can you put this in the context of other health crises that have happened over the decades, centuries? Where does this?
Yeah, you know, and sure, and it's a lot like other aspects of medicine. We know so much more now than we did 10 years ago, 20, 50 years ago. I mean, there's no comparison to 100 years ago with the quote Spanish flu. It really started in the US, but it's called the Spanish flu. There we didn't have much in the way of diagnostics and therapeutics, and you know, it killed an enormous number of individuals. When we got to SARS and MERS, we have better means of detection. We have better means of treatment. Again, if we pick the right kind of treatments. In this one, part of the issue is trying to do prevention on top of treatment. And we will see. I'm really glad we have a number of different countries. We have a number of different cohorts, both in the US and in other countries, to see what the best way might be to deal with this, because we'll have another one. These will occur, flu-like pandemics, coronavirus type pandemics. They will occur. So the more we learn from this, the better downstream. There are two ways of looking at this. On a population side, where again, various countries have done different things, we have to boil it down to how different the populations are, both in terms of the genetic and biologic profiles of individuals, but more importantly, the social determinants. And we have a saying in medicine that's become, I think, not just popular, but better understood the last 5 or 10 years, and that is zip code trumps genetic code. And it absolutely does in terms of your risk for a disease or an illness and your ability to respond and have effective treatment where you live and that environment has a lot more to do. It's probably 70%, and this is go online and there are plenty of references, probably 70% of the determinants as to your health and disease status are social rather than biologic and genetic. So, you know, right there, that tells you it's very hard to predict the right way to handle things, and how you deal with things in the Bronx or Manhattan are very different than in a suburb in rural Georgia, for example. So that's the challenge we have, and why it's just hard to extrapolate from past experience to what we're dealing with now. Over the next 6-12 months, we are going to learn a lot about this particular disease and this particular infection. The sooner we know, the better. But right now, trying all sorts of ways to deal with it at the individual level and at the population level is going to provide some useful information. It already has.
Tell me about the dealing with the diagnosis, though, and kind of how they're coming up with determining that.
Well, it's interesting when this started out, and again, this is an area that I know a fair amount, which means there's a lot I don't know. And I think in terms of diagnostics, there are a couple of situations. One is identifying the presence of the virus, and very early on, with the genetic testing that goes on, that's very, very specific. You don't get false positives, but it's not very sensitive. And sensitivity in any kind of diagnostic test, whether it's a cancer test or whatever test you might want to measure, there are two aspects to a test, and one we call analytic sensitivity and specificity, and that is how good is the test technically. But the other is biologic sensitivity and specificity. And for coronavirus, the problem is the biologic sensitivity of testing for the presence of virus with PCR is not that great for a variety of reasons. First of all, getting the right sample. Second of all, how the viruses, most viruses, can, in a sense, hide at different stages of the infection. So the areas you sample may be negative, but the individual may still have an infection. So PCR is a means of detecting virus, very specific, not very sensitive, especially in terms of biologic sensitivity. And then we have the other tests, and they're, first of all, in terms of that genetic testing for virus, which I presume people have heard about PCR testing, there are multiple platforms. So just talking with folks who run this at UCSD in San Diego, they run simultaneously 6 different platforms to measure the presence of virus by PCR because they're all different. And they have different analytic sensitivities and specificities. And sometimes some are positive and sometimes some are negative. And I remember my daughter, who's mentioned, who's an ICU nurse at NYU and in the first COVID unit at NYU and has been there for since the beginning of the first patients in New York that had severe COVID disease. She would say how many patients in their ICU unit would test negative twice by PCR. And yet they were sick and it was clear they had the disease. And that's, again, goes to how you use these tests. You really have to use diagnostic tests after you've used a couple of other tests. And I use that word test. And the key one is signs and symptoms. So, you know, if an individual has a lot of the signs and symptoms, you can start moving to diagnostic tests to see if they really have specificity and sensitivity to some extent. These antibody tests, there are just so many out there. The FDA finally, in the last day or a couple of days anyway, put a more rigorous threshold to approve the serology test. That means a blood test to look for antibody to the virus. And again, there you have real issues in terms of sensitivity, but also specificity, because the way these tests can cross-react with targets other than the virus makes for the presence of potentially false positive reactions as well. So again, a lot of work at Hopkins doing comparisons of all these different platforms, all these different technologies to measure antibody. Some are more sensitive to others, some are more specific than others. We're going to see how effective those are. But you know, at the end of the day, making a decision as to whether somebody is infected, still infectious, or immune, it's going to be a combination of these tests, but also the signs and symptoms. And there's going to be a lot of uncertainty as to how predictive these tests are, even when they might be as analytically sensitive and as specific as we would like them to be. So again, I think starting out with the signs, symptoms, the typical things we look for, and then applying these tests and then making a decision in terms of the predictive values, ultimately how we're going to be using these tests. But we're not there yet. We have a long way to go.
Well, while you've been talking, I've been personally inundated by questions privately by a lot of people.
Okay.
I know we're going to get to most of them at the end, but the first one that came through that I think is important, it kind of relates to the testing piece, is from Mike Ciulli in Geneseo. Wave your hand, Mike. He said, do you believe there is genuinely useful information to be gained by widespread testing of the population? And if so, which test do you believe to be the most useful?
Yeah, but that's a great question, and it's the $64,000 question. I think, again, we're going to have to see. We could do, and there's so many platforms, Rapid and so on, for PCRs, you know, and those type of tests and new derivatives of those tests that are being done. You know, that will give us some information of folks who have virus on board. But again, this is going to be transient. I think for most people, they'll have a transient infection. There's a good anecdotal data that for a lot of folks, they don't even have any signs or symptoms, and they can just clear the virus and develop antibodies. And, you know, that's what it is. It's sort of like a seasonal flu. A lot of us may not have any signs or symptoms, but we've had the flu and just didn't really know it. Others have some signs and symptoms. Others in the hospital, and a lot of folks die. So that's one aspect. The antibody testing, you're going to have to be in the right window to see a response. And what are you testing for? And if you're into this area, you know, the IgMs come up earlier than the IgGs. The IgGs may be longer sustaining. They could be dampened. The longer you wait past an infection, the more sensitive you need to test, but that also makes it more less specific in most cases, and you can get a lot of false positives. So the value, your question about the value of this, value will be to some extent realizing their false positives and false negatives, just to give us an idea of what is the frequency in the population roughly that is at risk for infection, and then as part of that risk of infection, at risk of disease. So, testing everybody's going to be a bit misleading if we use it to get everybody back to work for a number of folks. But overall, there's probably some value in doing that. And, this is going on in other countries that already have been through this, and that you're seeing in terms of symptoms of diminution in the number of active cases. It's going to be very interesting to see what their testing shows. I don't know if that answered your question. You really can't answer that question. I'm giving you, the bookends of how useful these might be. Very useful on the one hand, not useful at all, and misleading on the other hand. That's a problem.
Well, from the diagnosis and the testing comes the potential treatments that are out there. I know Nancy Jones asked a question about the is it the remdesivir? The new drug, the drug that's out there for lupus treatments. But what are the current available treatments out there now, and or that they're testing? What's that looking like?
Yeah, well, the treatments, again, most treatments, and certainly initially, have been supportive therapy for the lung disease, or if it's cardiac symptoms or renal disease, dialysis, and so on. So again, that is the way we deal with patients generally. First is you treat the symptoms. If you can identify therapeutics that are effective, that's great. The hydroxychloroquine and chloroquine story did not bear out, primarily because the side effects are so great. And I think many people predicted that, but some of the early data that came out of China, and I'm going back 4 or 5 weeks ago, and this was even longer, we're just starting up in the US. A lot of folks were looking to the data that was coming out of China, early data that suggested those drugs might be useful. The Gilead trial for remdesivir is showing that there is some benefit in terms of getting folks out of the hospital a little quicker. The mortality might be reduced by maybe a third, 12% down to 8%. We'll see. We'll have to see what the side effects are. Have to see what the appropriate usage is. I like to remind people, baby aspirin daily is not absolutely benign in everybody in the population. We have had some great drugs that after they were on the market, you found out there were some significant problems. Hopefully that won't be the case here. There are a number of, as we were understanding the mechanism of disease here, and especially the specific inflammatory cytokines that create the pulmonary disease and probably are causing some of the other diseases and the inflammatory diseases. There are a couple of interesting approaches that dampen cytokine production that have been used clinically, and some that we're particularly interested in, the foundation. One is high-dose intravenous vitamin C, which has been used in a lot of patients in 2 large clinical trials, FDA-approved, randomized controlled clinical trials. One was published in JAMA last year. It's absolutely safe. It's been used in thousands of patients who have cancer as a means of diminishing the side effects of chemotherapy. But it's also been used for septic shock. And again, when you go into the ICU and you have these problems, whether with a virus or bacteria, it's sort of septic shock. And these 2 trials suggest, but have not shown, that this is effective. It's the way you get into trial design and so on. But for the one trial published in JAMA with vitamin C, mortality was significantly lower. ICU days was significantly lower. And hospital days were statistically significantly lower in patients who got high-dose IV vitamin C, who had ARDS in the ICU. So there are a lot of trials going on now looking at that in particular, because if you're in the ICU with an IV, it's absolutely safe and benign and cheap because it's not proprietary. Another approach has been looking at other natural products. These are early on that reduce the inflammatory damage in the lung. Very early, we'll have to see. There really are not clinical trials yet or past clinical data supporting those. One that is, I just saw today, that has become very active. A lot of trials in China that are showing benefit. A lot of compassionate use now in the US. Familiar with what's going on now at 4 different institutions with compassionate use using cell therapy. And these are called mesenchymal stromal cells, MSCs. They have an abbreviation. They can come from either adipose tissue, fat. They can come from bone marrow, or they can come from placental umbilical cords. And these cells have been used extensively in trials around the world for a variety of inflammatory disorders. A key one is graft versus host disease, which has a similar inflammatory pattern in the gut as we're seeing COVID induces in the lung. The anecdotes, and I'm familiar with quite a few, and we did a literature review with the Mayo Clinic on the world's literature for using these cells for ARDS, and there are about 200 patients in trials where this has been used. It has a pretty significant benefit in reducing mortality in patients with ARDS. And the patients who have been treated with this anecdotally, and they've been in the paper, so I don't know if they've been on the media, but are showing pretty remarkable results. And these are ICU patients who would have a high prediction of dying from the COVID infection, who are doing very well and being discharged. Now, again, with multiple trials are now underway, have started, that the FDA have approved. What I'm talking about are anecdotes for compassionate use, as it's called, for at least 6, 12, at least about 20 patients so far that I know of. And I'm adding this up in my head, but probably 16 of them have had very significant responses with this type of treatment. And of course, the ultimate treatment is vaccine. And there are at least 70 teams that are involved in developing vaccines. There are at least 16 clinical trials going on with different vaccines. A lot of money from BARDA has gone into this. A lot of money from a philanthropy consortium, $2 billion they put together in looking at a variety of vaccines. So, as we've seen with a variety of other, not all cases, but in many cases, the development of an effective vaccine in a hopefully a reasonable time frame to allow some of the folks who are at high risk for disease to be able to benefit by having a vaccine.
I know we're going to get to like the effects of where this is going to take us, what this means for us in the future. But before we do, there's a couple questions that are related to social distancing that I wanted to see what your thoughts are. And
Sure.
Gary, our foundation board president, said, how safe is it to get together with 3 or 4 family members at a time who have been safe in their own homes, working from home, staying out of stores? And then another question was, when would it be safe to go back on a plane for business reasons? Or
Yeah.
So there's 2 different questions from Greg, and there's 2 different questions more about like how
Yeah. Well, folks like us who have self-quarantined since the beginning, and we're, been not in touch with folks in terms of distancing for weeks. I think for folks like that to get together where they have no signs, no symptoms, and no exposure and so on, that's pretty safe. I think that would be pretty safe. Getting together with folks who have contact with folks who may be infected, that's a different story because of the lag time in demonstrating signs and symptoms of infection. And as I said, a pretty high percent of individuals, maybe, we don't know, but I think the data probably will show there are a high percent of individuals who won't show any signs and symptoms. And so getting together with folks who have been in contact, who may have been infected, have no signs and symptoms, that's one issue. Now, again, signs and symptoms, coughing, and I'm sure this is very well publicized. I'm not sure how well publicized. One of the early symptoms is basically low oxygenation. So, if you're going to get together with folks, that's one of the early signs as well, is to look if people have oximeters to be testing their own oxygenation. If that has changed, that might be an early suggestion of having an infection where you didn't have other signs or symptoms. Planes, I was talking with a colleague who flew from Raleigh-Durham to Dallas-Fort Worth. He was the only one on the plane.
wow.
He was the only one he saw. Now, this is a week and a half, 2 weeks ago, so I don't know if it's changed much. But again, it was pretty amazing back then. Nobody in the airport, et cetera, et cetera. The airlines are doing social distancing. We're very much involved with Delta Airline here in Atlanta. happen to know some of those folks pretty well, board chair and so on. They're being very careful because what you don't want is a real disaster when you start opening this up. So again, how they're cleaning the planes, et cetera. My advice to folks is basically what kind of risk category are you in and what kind of risk are you willing to take? It's not that different from folks who get a diagnosis of, you name it, whether it's cardiovascular disease or cancer, whatever. There are a variety of treatment options. There are a variety of risks you can take. And as long as you're as well informed as you can be, the decision is up to you. At the start of this, a lot of people joke, not so much a joke, it was safer to be in Atlanta Airport than drive to Atlanta Airport with all the wrecks that go on here in Atlanta. So again, I think these are individual decisions. Look at your risk profile, look at who you're going to be associating with. And with some of the testing, again, if you're found to have high levels of antibody and, retested and you don't have a false positive, you're probably in reasonable shape as being immune. And those tests will be coming on board, believe me. The market is driving a lot of testing, which is good and bad.
There's some questions I think people are starting to answer themselves over here, but they're about why does it seem like America has more, United States has more cases reported, raw numbers, deaths? Like, what do you think it is about the United States, why that's happening?
Well, again, United States, let's talk about what's going on in some areas and versus others. New York, obviously, Detroit, some areas, it's really bad. It's as bad, and if not worse, than some of the isolated areas that were very severe. But there are other parts of the country where there's just very little going on, very little. So as a country, I think the behaviors we see in some areas, and especially in New York, where there's a lot of interaction early on with folks who've been traveling and bringing and distributing a high density of potential infections. So a different situation. Again, I go back to the social determinants, and we're seeing that folks that are high risk for any disease in a sense, or a problem if they got any disease, they're the ones who are in higher density in many of these locations and are showing very unfortunate outcomes. We saw a case in an early situation here in Georgia, in Albany. Atlanta has not had that much problem. Our capacity to deal with this has been great. We have plenty of excess capacity to be able to deal with the surge, as do, I'd say, a majority of communities in most cities. And I'm in touch with a lot of folks who are involved in these things in most cities. Some are not. So the numbers are skewed in certain areas. And I think you can look at China. Look at China the same way. The overall, it's a much bigger country than ours. Look at the numbers of death and you say, oh, overall, not much. But you look at a couple of cities where it was bad. I mean, it was bad and had a high percent. So I think you have to put things in context.
Percentage and
yeah.
How somebody asked, Nick asked, how long does the virus persist in public spaces? I guess there's been a lot of question about it being airborne and things like that. Any special considerations for when you have to go out?
I think common sense, wear a mask, wash if you've touched things. It's interesting, our benefactor for the foundation years ago, so he has pulmonary, he's very public about it, so he has pulmonary issues. I mean, he'd been fisting and elbowing going back years and years because he can't really suffer a pulmonary infection and so on. So I think using common sense, being safe, understanding that transmission is very similar to what we know for flu and what folks did when flu was seasonal flu was rampant and is reasonable. I think the issue is, again, if you're at particularly high risk, you got to be a little extra careful. And we know age is a high risk. It's probably the same proportion. If you look at the stats that come out from the CDC over seasonal flu every year, we're looking at somewhat the same risk profile proportionately in terms of age, in terms of social determinants and so on for coronavirus as we do for seasonal flu. I mean, those are the folks who are at higher risk. Older, pulmonary symptoms, confounding medical problems, low socioeconomic state, those are the risk factors that you have to add into the mix of just being masked and being careful with what you touch and then how you touch yourself. I think the big issue is going to be if there is fecal transmission, oral fecal, that adds another risk to it. But I think if that's the case, we would have known about that by now from all the work being done in China and Italy. But still remains to be seen.
There's I think it's credible. It's pretty commendable that you don't really watch the news at all, and I think it's where a lot of us get our information. And you would never know where to go. Where would you recommend folks that are not necessarily in the know? Where would you go to for your sources of information?
Yeah, there are a lot of, and again, the medical sources, whether it's WebMD or what's coming out in JAMA or New England Journal. And again, you have to take all of that with a grain of salt as well. You can get out published in JAMA and the New England Journal. There's a lot of stuff published there that you take with a grain of salt. And frankly, it's true, before coronavirus, most clinical trials that were rigorous, randomized controlled clinical trials are not reproducible. I can go into that if we had an hour. So yeah, we have to be very careful, but I think you can go online, look at some of these websites, look at some of the publications. I mean, there's a long list. I could send you a list of some of the medical websites that provide updates on whether it's diagnostics or therapeutics or disease entity and so on, that provide more data than opinion. And I like opinion, but you have to get a broad array of opinions or you're going to get a very biased view based on, what the media is in business for as entertainment and revenue generation through advertising and political commentary based on, who's in charge of those particular media outlets. So
give me a chance of this. You could send me a list and I can send it out to participants.
Sure.
Of, recommended sites and everything. Just like I said, I try not to watch TV every day. I try not to watch.
You have to be a subscriber. That's the problem with a lot of the core medical. Yeah. You have to be a subscriber, and that is a bit of a problem. As soon as you get to the more generic, then they're dependent more on advertising, and you start, getting sensational type of reporting rather than news and facts.
I want to get into the kind of the final question, the final talking point, and see if there's more questions, but related to how this is going to transform us or change healthcare, beyond this. But I think there's still some questions about, there's still that sense of panic that's out there, probably sensationalized by the media a little bit, not necessarily on fact, but you go out to a grocery store, you go outside and you see anywhere from people wearing masks to big sunglasses and gloves and sanitizing and swapping gloves out. Is that overboard? Is that, or do you go back to depends on what risk category you're in again?
Yeah, I think it goes back to your personal preference and your willingness to take risk. I mean, not all of us will climb a particular mountain or drive on. My wife doesn't drive on the connector here in Atlanta because no matter when you drive on it, not now, but a few months ago, there'd always be accidents. I mean, how many accidents do you see along there? So, it depends what kind of risks you want to take. I always say you have to be as well informed as possible. So your point about this, though, I drive around town. I like to see how things are going. And it's interesting to me when I drive to the shopping centers, and this is going back 3 weeks, 2 weeks, a week ago, and so on. There's a mix of people going into these shopping grocery stores without any mask, and then there are others, as you say, fully gowned. Now, we have to be careful because you don't want folks who are not protecting themselves and not reducing the risk of infecting others. That's a real issue. That is a public health issue. So we have to be careful in letting folks determine their own risk as it impinges on the risk of others. Good analogy we've had for certainly through my lifetime is smoking as a personal risk factor versus a public risk factor, and how we've dealt with that quite a bit differently in the last 10, 15 years and how that has evolved in different communities. So I think different communities are dealing with this differently. I talked to people out in California, Southern California, and Scripps and San Diego, and they just have not seen the level of problems that some other communities, even out in California, have, and likewise here in Atlanta, and likewise in Ohio or Pennsylvania, New York as well. So try to make the decision for yourself, and it's kind of hard to generalize from what the media is saying. I assume they're saying to everybody. You just can't.
Well, I think the big question is like, where do we go from here? And I've been on several calls and webinars with colleagues of mine at institutions, admissions offices for colleges, and they say, they're seeing changes in acceptance rates because students are trying to go that would normally have gone to like an NYU or a large school in a major city are opting for maybe plan B and going out into farm country USA school because it seems to be cleaner. So people are making decisions for themselves based on where they think it's going to be less crowded or less.
Yeah, sure. They are.
Is that kind of a sign of the times of what's to come for us?
I think for some students, it certainly is. I look at, I've had two kids who've gone to college, and, there's so many decisions that go into where they want to go. I was talking with the president of Duke last week, and what they're going to be doing there. And obviously, there are a lot of factors. Is this going to, I think the two biggest areas is going to change. Two of the biggest areas is going to change. Obviously, for some industries, it's huge, but is healthcare delivery and higher education. They really are going to be changed by this because there's been an acceleration of what we're being able to do as we're doing right now. Certainly telemedicine has been around a long time, but being able to have individuals feel comfortable with it, be able to do it comprehensively, be able to be frankly reimbursed for it. I mean, a lot of the resistance has been the absence of reimbursement. CMS is changing that and has changed that. We're going to see some significant differences there. And a lot of the sensor devices that have been developed are remarkable already for being able to do telehealth. I think for education, if you will, I think I mentioned before the call, I teach a course in the fall, and for 2 years been using Zoom because we have students who take the course. It's a health services research course who are not at Emory. It's just, people are going to be scratching their heads and saying, do I go to school for the social experience or the knowledge and the education? And if it's just the knowledge and education, you can get a lot of that, much more cost effectively and tailored to your own learning habits by doing it in a sense online. The ability also in healthcare, and we've done a study with 8 medical schools looking at virtual patient simulators to teach medical students how to diagnose illnesses. And this was before any of this COVID. This was over the last year or so. And we have a center actually at the University of Chicago that's amplifying this and sending out the tools. Using virtual patient simulators for medical students improves their diagnostic competency enormously over what the traditional medical school curriculum provides. And there are a lot of good reasons for that and anticipation. So I think we're going to see an acceleration of using these virtual models for education and healthcare in particular, and it's going to change the way these entities operate. I think we're also seeing already a change in the way clinical trials can be done. The FDA and CMS have really changed the way things are going on. I was, again, on the phone last week with the head of CBER at the FDA, who oversees all of biologics, and actually he's the new czar for vaccines. They've had to change completely the way they approve compassionate use, approve clinical trials, because this harkens back to HIV. For those of us who remember that very well, and how societal needs and public demands change the way regulations work to accelerate potential treatments into the community. So I think we're going to be seeing some changes in healthcare from that perspective as well.
I'm going to see if we have other questions. Bob Mervos, he put in there, he said, you mentioned oxygenation, is that right? Oxygenation? Yeah. Is that something we should be checking ourselves?
Yeah, why not? It's easy to get. I don't know if they're still available easily or not. As soon as I don't know if the media has been pushing that, but if the media starts pushing stuff, all of a sudden, boom, everybody gets it. But yeah, if you're at risk or you're interacting with folks who may be likely to be infectious, even if they're not even symptomatic, can't hurt. It's an early sign symptom, and if you have low oxygen tension, it'd be nice to know that. So, yeah, frankly, I do, not frequently, but I do. I'm asthmatic. Interestingly, when this all started, I told my wife, I'm not sure, understanding the mechanism of asthma, whether I would be protected versus at greater risk. And I was just seeing some of the summary data today coming out that indeed asthmatics may be protected in a sense because of the way we respond in different inflammatory means than most people to toxins in our lungs, which is interesting.
Chris Richwine just asked, Fred, do you have any insight as to why it took so long for the model, University of Washington, to become anywhere near reliable? One would think a model updating routine would have yielded quicker results.
It's the data collection that's the problem, isn't it? And the reporting. And again, this is a confounder. Looking at incidence of infection and cases and so on is dependent to a large extent on reporting, especially early on. Look, we had seasonal flu going on, the end of seasonal flu going on with the beginning of coronavirus. So patients rolling into the ICU with these symptoms, was it seasonal flu? Was it coronavirus? Because there's some overlap there. And as I said, there were patients who would be tested and negative, but downstream found out to be positive. And a lot of this was, so anyway, I'm not that comfortable with all the data that are out there. I track the various sources of data that come through, but you have to realize they're incomplete and to some extent inaccurate, even with the best of it right now. So why did it take so long? For those reasons, and we're not there yet. I mean, do we know what the prevalence of this is in the population? No. We don't. Do we know in China what it is? No. In certain cohorts, we do, where you can test everybody. But the testing, again, has to be done very carefully because of all the false negatives and positives these different tests give us. Sorry, I wish there were better answers.
Yeah.
But
to be continued. We still have about 7 or 8 minutes left, and I wanted to give anybody else an opportunity to unmute and ask a question, make a comment, hear themselves talk over the computer. I don't know, Gary or Byron, Nancy. I'm looking at all the different people going on the list.
I would like to say thank you, Fred, for coming here and meeting with us virtually about all the information, giving us all the information that that you have at your fingertips, and clearing up a few things that I'm sure many people feel might have been in the news and not as clear as what you made it. I really appreciate it, and of course your support over the years and all of that. So I just wanted to say that as the president, I appreciate that, and thank you so much.
Well, thank you. I hope I made some things clear rather than confuse them. They're not simple. No, there's some individuals worth listening to. I've been a big fan of Tom Frieden for a while when he was CDC director here in Atlanta and so on. And he's somebody who can give a well-balanced approach. Again, I don't know where these people are on the media. I hear some folks are on the media and others aren't. You have to realize everybody comes at this from their own perspective. So if you want to hear it from a public health perspective, Tom is great. If you want to hear it from ID perspective, infectious disease perspective, Tony Fauci is great and lived through the. If it depends what perspective. Yeah, the other thing we have to remember in all this, and again, the data are going to be very important in terms of the impact of this disease. I didn't mention it earlier, and I should have, as far as the disease. And there's been a lot of tracking of this. The American Heart does a great job tracking the reduction in number of patients who have heart attacks and strokes going to the emergency room and into the hospital is very frightening. And clearly there is an increased incidence of death because of that, the number of patients. I just saw an article coming out that was tracking the reduced number of patients with cancer who have been going to the hospital for their treatments or their diagnosis. And, you know, some of those you delay treatment or you delay diagnosis. I mean, that is devastating. So we're going to see a lot of secondary effects of both morbidity and mortality because people are just not going to the emergency rooms and hospitals. And I'm glad, again, for like us here in Atlanta and others, hospitals, health systems are reopening clinics, reopening emergency rooms to broader populations, because we don't want those folks to have to suffer as well. But, you know, they are suffering from this pandemic. It's having some very broad impact in terms of healthcare for a lot of folks.
The other thing I wanted to do was I just wanted to thank Jay for putting this together. And, you know, if it wasn't for him, we wouldn't have been here having this. And certainly many of the brothers who are on are people and brothers that are very helpful in making sure the foundation continues on and does what it can. Now we're in more need than any other time, seeing that we have a lot of young men who are looking for, you know, more money, you know, as scholarships and that. And so I just, you know, wanted to thank Jay for getting all of you who are involved, and hope that you stay involved and continue on. I know that Jay has a couple more considerations. I know we have one more set up, and I hope that you all show up. And thank you so much once again, Fred and Jay, for doing that. And now, with that, I will be quiet.
I think one of the point is valid. Just keep bringing it back to the fraternity is that, you know, seeing all the schools close down and, you know, the idea of fraternity, we are anticipating that there will be a lot of financial hardships. There may be students that may not be able to come back to school or afford it. What it looks like life on campus is going to look a little bit different. I mean, so far from what I understand, our director of communications, Nick Hughley, had said that all of the schools except for one, I think, still has no decision on what's going to happen yet. I think everybody's waiting to see who's going to push play on their plan first, and then kind of follow suit that way. But I anticipate that we're going to have more of a financial need from our men for loans, grants, assistance in some way, whether it's they're losing, because a lot of our guys pay their way through school. You know, they're working, and it's difficult. So it's affecting everybody. I will say that there's we're going to send a survey just to get an idea of like future topics and kind of this setup here, what you like. But Fred, I really want to thank you again for coming on and do this. We did record this, so you will, you'll probably get 2 emails. One has the survey and a link for donations if you'd like to contribute to be able to make more things like this happen for our undergraduates and our graduate men. But you'll get a second email that'll have the recording of this for safekeeping, and we'll look to get this posted somewhere on our website so people can have an easy link for this information. With your permission, Fred.
Sure.
I probably should ask that first.
Sure.
You're expert. Any other final thoughts, Fred?
No, I hope this was helpful. I guess folks stayed on, so maybe it was, or at least with Zoom, you know, you're able to do some other things sometimes while you're listening.
There you go. Did you? Not to put you on the spot. Well, I'll put you on the spot. But you definitely helped help the foundation financially, not only with scholarships, but you also are a big proponent in piloting our coach program, our Pro Coach program, which has really been successful these last couple of years. What would you say to someone who is thinking about contributing to the foundation? What was the reason for why you did what you did?
Well, you know, I did for the scholarship. I think scholarships are so important for those in need and need support. And I provide a lot of support for scholarships at a variety of the institutions I've been at a variety of levels. But the coaching program, and this is something you brought to my attention, just seemed like a great idea, and the impact it was having at a variety of institutions was significant. I think, that's one of the things that is most important for kids going to college in terms of being able to get advice and career advice and such. So it seemed very worthwhile, and I think is a tribute to the fraternity to have started that up. I think this was really something started by Alpha Chi Rho and has been very successful. So I'm glad I was just able to help demonstrate that it was going to be successful and expand it and continue it.
I do appreciate it.
Others should give to it. It's key. If you're interested in our future and our future generations, this is important.
We have a couple big contributors on this call and a couple people that have also endowed scholarships too. So we do appreciate all of our lifetime givers. I won't embarrass them though.
Yeah. Well,
thank you very much. It's 4 o'clock. Thanks for this. Our second.
Jay?
Yes.
Yeah, for those that have a curiosity about flying on airplanes, as a career Air Force aviator, I would just say that in general, airplanes are not designed to segregate their air handling systems. So in most airplanes, and this would probably be almost all passenger airplanes, the air that you breathe and exhale in the passenger compartment spreads to the whole passenger compartment. So that fellow that was the only passenger on the airplane was relatively safe as long as the crew was safe. But if you put 30 people, even if they're distanced, everyone breathing in that air will be breathing what everyone else is exhaling over the course of the flight.
So I guess I'll be in Florida forever.
Well, I have comorbidities. It's going to be a long time before I fly on a commercial airplane again.
I got to get home to Jersey, but I don't think that's any better. But
Thank you for that.
Always rent a car.
that's it. Exactly.
All right, the next one is next Tuesday, the 12th. It is about the how the pandemic is affecting $110 billion industry, America's beer industry. And so that'll be an interesting comment from someone who works for Anheuser-Busch, and one of Westchester grads. So that'll be the next one. Suggestions in the survey to let us know what else you'd like or recommendations for people who would be a great topic leader. Just send them our way in the survey. Again, Fred, thanks, Gary, and the rest of the board that's on here, and all of you for participating. You'll be getting an email about this shortly.
Great.
Thank you so much.
Thanks, everybody.
thank you.
Thanks, Jay.
Bye.
Fred, send that list
Thank
along.
you.